we will be focusing specifically on level 5. The objectives today are to review the anatomic borders for level 5, to review primary echelon lymphatic drainage patterns for head and neck tumors, and to review the one relevant organ at risk in the vicinity of level 5. Sort of like Ben was saying earlier, this is a safe learning environment, free from judgment. In order to learn, we must first acknowledge that we don't know things. It's okay to not know the answer. It's okay to give an incorrect answer. There is value to being wrong because the reality is all of these are very important in the learning process. So for today's session, if everyone could focus on being open, being present, and participating, then I think we can all get a lot out of this. So level 5 is known as the posterior triangle. It's located posterior to the sternocleidomastoid muscle and is located around the spinal accessory nerve as well as the transverse cervical vessels. Today, we're going to be focusing on the radiographic anatomic definitions of lymph node levels. And most specifically, we're going to be focusing on the 2013 atlas as published in the Green Journal back in 2013 by Vincent Gregoire. As far as the borders go, we'll go ahead and start at the superior aspect of level 5. So we are again talking about the posterior triangle. Superiorly, this is going to start at the level of the cranial edge of the body of the hyoid. And move this down here. So the first question we have is, what other lymph nodes use the hyoid bone or the CT slice that is at the level of the hyoid bone as an anatomical boundary? Go ahead and put some of the answers in the chat here.
Dr. Lisa?
Right. Yes.
Yeah, 2 and 3, 2 and 3. Yeah.
Yeah, excellent.
Right. Yeah.
So those are some of the lymph node levels that you've already learned. So yes, levels 2 and 3, the boundary between them is defined as the caudal edge of the body of the hyoid. So that is slightly different than level 5, which is the level of the cranial edge of the body of the hyoid. In addition to the boundary between level 2 and 3, the superior border of level 6A also is the caudal edge of the body of the hyoid. And then another example of a lymph node level that uses the hyoid bone as an anatomical boundary would also be the retropharyngeal node. So that's level 7A. The inferior border is at the cranial edge of the body of the hyoid. So I bring this up just simply because sometimes it can be helpful as we're learning to start making associations, and sometimes thinking of these things being grouped together to know what parts of the hyoid are pertinent for which lymph node levels, I think is a useful way to see the information portrayed. Moving on, the inferior border is the CT slice, that is the plane inferior to the transverse cervical vessels. The anterior border is the posterior edge of the sternocleidomastoid muscles. So I'm going to pause here and ask another question. What lymph node levels use the posterior border of the sternocleidomastoid as an anatomical boundary? And you can go ahead and put that answer in the chat as well.
Some people write level 2, level 2, 3.
Exactly. And so as we're thinking about levels 2, 3, and 4, the posterior border for all of those levels is the posterior border of the sternocleidomastoid. And then the anterior border of level 5 is the posterior aspect of the sternocleidomastoid. Moving on, the posterior border is the plane defined by the anterior border of the trapezius muscle. Laterally, the anatomical level goes to the platysma and skin, and medially that border is defined by the levator scapulae and scalenus muscle. Level 5 is split into 5A and 5B, which is more of surgical importance. And it's basically a superior and inferior way to split level 5. So it's split at the level of the caudal aspect of the cricoid cartilage. From the standpoint of what we do in radiation therapy, if you want to contour level 5, most of the time you're contouring all of level 5. Very rarely would we be splitting this into 5A and 5B. So for my purposes, as I think about contouring, I'm usually thinking about level 5 as a whole. As far as drainage to level 5, what would be the superior continuation of level 5? So as we were saying earlier, level 5 is the posterior triangle. So this means that it receives efferent lymphatic drainage from the retroauricular nodes, that's 10A, the occipital nodes, that's 10B, and then also level 2B. In the most modern imaging lymph node level atlas, level 2 is not well defined, as split into 2A and 2B. But I do think that there is some important historical significance here. And in some cases, it's probably useful to understand the differences between levels 2A and 2B. So much earlier to this atlas that we're studying, that was published back in 2013, lymph node levels were first defined by surgical anatomy. When we look back to the early surgical anatomical definitions as per Robbins et al., level 2A and 2B were split by the spinal accessory nerve. So this created an anterior and a posterior aspect to cervical level 2 lymph nodes. As time evolved and the way we treated patients evolved, we needed to transition these surgical definitions to imaging. As such, we did have an intermediary anatomical lymph node level system that was defined off of two-dimensional imaging, like plain X-ray. And then it was in 2003 that we first started transitioning this to three-dimensional anatomy. Now, as we can see, or maybe I should say as we can't see, the spinal accessory nerve is unfortunately just too small to be a useful radiographic landmark on CT scan. And that's one of the limitations of that surgical system by Robbins et al. So in light of that, the experts met and determined a CT-based anatomical landmark that could be easily identified as a surrogate for where the spinal accessory nerve ran. The new guidelines, as per the first CT guidelines published back in 2003, use the posterior edge of the internal jugular vein to divide levels 2A and 2B. I think it's important to note that it was a little bit more complicated than that. To be a true 2B lymph node, that lymph node had to be posterior to the internal jugular vein and not touching it, meaning you could see a visual fat space in between the vein and your lymph node. These are the radiographic images of the lymph nodes as they're drawn in the original CT-based atlas from 2003. Again, splitting level 2 into an anterior and a posterior aspect. Many experts believe that level 2B represents spinal accessory chain and is more of a posterior neck lymphatic drainage site. And I think that's useful because as we're thinking about seeing lymph nodes in this area, things that would drain and be at high risk for level 2B would also be things that would be considered high risk for involvement of lymph nodes in level 5. So here, the CT slides, we have a few examples of lymph nodes. This first one up here is a normal appearing level 1B node with a nice fatty hilum. Going more posteriorly, we have a very anterior level 2A node, which is obviously enlarged and is malignant just simply based on size criteria, greater than 1 centimeter on axial slice. And then more posteriorly, this little lymph node back here would be considered a level 2B. And so this lymph node here, as well as these other tiny little lymph nodes, would be part of that posterior cervical chain lymphatic drainage. What happens if you see a patient present with a level 5 lymph node with an otherwise unknown primary site? There should be 2 primary sites that should be at the top of your differential diagnosis for a level 5 lymph node presentation when it's level 5 only. And those 2 primary sites should definitely be a nasopharynx primary. Nasopharynx cancer is very commonly drained to level 5. And the other would be a cutaneous malignancy at high risk for lymphatic involvement located along the posterior scalp as well as the posterior lateral neck could also drain to level 5. So for level 5 lymph nodes, in general, you would consider the primary echelon drainage from nasopharynx and cutaneous cancers of the posterior lateral neck and scalp, as we just mentioned. In general terms, other subsites of the head and neck that very commonly would drain to level 5 as a first or second echelon would be oropharyngeal cancers and thyroid malignancies. It's not common that we treat thyroid malignancies with external beam radiation therapy, but I do think that it's useful to remember when you see the occasional anaplastic thyroid that you're going to be treating with external beam, that you should always be including level 5 in your volumes electively. So next we're going to get into an anatomical question here. Which of the following CT scan slices best represents the superior border of level 5? And you can go ahead and put your answers in the chat.
Okay.
I think this is a separate question that's polling.
Okay. Some people ask where D, but
Okay. And then I have the poll.
D. Okay. The poll,
So the
tried.
poll is a different question that comes at the end of the lecture and is not the question that goes with this particular slide that we're on.
Okay, sorry.
That's okay. We'll get to that in a second. So I apologize to the audience for the confusion. I promise that we will get to this question in another few minutes. I'm going to go ahead and close this out of my screen. For the purposes of this current question, which of the following CT scan slices best represents the superior border of level 5?
Most of the people answer D and C.
Okay. So the correct answer is actually A. So as we can remember, the superior border of level 5 is at the superior or the cranial edge of the body of the hyoid bone. And so I'm intentionally giving you some tricky CT slices with some distractors in there. So if we look more carefully at the images, what exactly are we looking at? So here what I'm trying to show you is we have the hyoid bone just starting, so you can see just the very superior aspect of that bone along the bright white here. In B, what we're looking at is we're at the level of the mid body of the hyoid bone. In level C, we're at the inferior aspect of the hyoid bone. And then in level D, what I'm showing you is the very superior aspect of the thyroid cartilage, which is within the larynx. And so I'm intentionally showing you this now because at first glance, if you're not paying very close attention, it can be very easy to confuse the hyoid bone with the thyroid cartilage, just very simply because both of them look bright white and they're sort of like a horseshoe shape in the anterior neck. So I think it's always important as you're scrolling through your image set, make sure that you have clarification of whether or not you're looking at the hyoid bone versus the thyroid cartilage. Here I'm giving you still images. In real life, of course, once you identify the hyoid bone, you would be able to scroll up and down to find the level of the superior aspect of the hyoid. And I also will point out too, this is a little bit of a tricky picture because what we have here too is a vallecula tumor enhancing here and growing right into the plane where the hyoid is. So this is a little bit of a tricky image too. So the next question we have is, which structure marks the anterior border of level 5? Which structure marks the anterior border of level 5?
Bueno, nos ayudan dando respuesta en el chat. ¿Cuál estructura marca el límite anterior o el borde anterior del nivel 5? Some people answer C. Yeah.
Yes,
C.
excellent. And that's
Yeah.
correct. So as far as the anatomy goes, A right here is the jugular vein. B is the middle scalene muscle. C, I'm placing that red dot right at the posterior aspect of the sternocleidomastoid muscle. And then D is the transverse process of C6. Next, we have these representative CT slices. On these CT slices, which structure represents the posterior border of level 5?
B, E.
Yep.
B
B
and
and E, exactly.
B and E.
So A, we have the posterior edge of the sternocleidomastoid. B, we have the anterior edge of the trapezius. C is the middle scalene again. D is the posterior aspect of the trapezius. And then E is also the anterior edge of the trapezius. So that muscle can look very different depending on exactly what level we are within the neck. Which of the following structures best represents the lateral aspect of level 5?
Okay, the most of the people answer E, C,
Excellent.
C,
Excellent.
C, yeah. E and C, some of the people.
Exactly. And so here we are showing you A is the levator scapulae, B is the sternocleidomastoid, C, we have the skin. So up high in level 5 or superiorly, we're contouring to the skin surface, or not skin surface, I'm sorry, but the deep aspect of the skin. D, we have the middle scalene muscle again, and then E is the clavicle. Sorry. And then next we have, which of the structures represents the medial aspect of level 5? So here that would be A.
Okay. There is no answer. Some people put C, A and D.
Yep, exactly. And so again, A is the levator scapulae, and then D is the middle scalene. So those would be representative of the medial aspect of level 5. The plane below which blood vessel marks the inferior border of level 5? So which blood vessel do we identify to help us mark the inferior aspect of level 5?
Yeah.
Exactly.
People,
Perfect.
B, yeah.
Yep,
Perfect.
perfect.
Mhm.
Yep. So A is the right jugular. Oops, sorry about that. B, we have the transverse cervical. C, we have the common carotid. And then D, we have the left subclavian. Here are some contour examples of level 5. So this is right directly from the Gregoire Atlas. Here is a case that I have treated in the past. So this is me attempting to contour in level 5 electively on this patient in green.
Dr. Liz, I have a question in previously slide. In the third image, I always have this particular question that when you get a little bit in between of the muscle, because you know it's the anterior board of the trapezius, yeah, but when you use, wait, I see if I can, okay, I don't know, the concavous part of between the muscle, when you go further, when it's compromised, this level 5.
Are you asking when would you
Yeah.
come back more posteriorly?
Yeah, more posteriorly.
And I think that's a really great question. With any lymph node level, I think it's important to keep in mind that these anatomical boundaries are basically creating a model. And anatomy can vary very much from individual to individual. And so I think if we're going to consider, how to stylistically modify this on an individual basis, first and foremost, I think it's important to scroll through your entire image set before you even start contouring.
Okay.
If you can visualize any lymph nodes deeper, so more posteriorly than what the traditional contour is, that would definitely be an indication where you would want to bring your contours more posteriorly. In a situation like this, where you have a known malignancy, even if it's a small lymph node that is not PET avid and does not otherwise meet CT-based criteria for malignant positivity, even if it's just a small lymph node that's visible, but just immediately outside of what I would be contouring, I would go ahead and include that. The other indication for coming back and treating the whole posterior aspect of this fat space here would be as if you had a very large tumor burden volume in the lymphatics in that ipsilateral neck. And that's not necessarily something that's well defined that experts are going to agree on. But if you have a lot of lymph nodes, and then in particular, a lot of lymph nodes in level 5, I would go ahead and include this more posteriorly.
Thank you.
Yeah, that's a really, really good question. Last, we'll get into level 5C. So level 5A and 5B are considered to be the posterior triangle. Level 5C is considered to be the lateral supraclavicular node. Their borders are defined superiorly by the plane inferior to the transverse cervical vessels. Inferiorly, they stop 2 centimeters cranial to the sternal manubrium. So this is also the anatomical division between 4A and 4B. Anteriorly, the border is the skin. Posteriorly, the border is the anterior border of the trapezius cranially. And then about 1 centimeter anterior to the serratus muscle caudally. Laterally, this is contoured to the trapezius, and then medially to the scalenus and lateral edge of the sternocleidomastoid. So in this situation, these are really the lateral supraclavicular nodes. The other probably most common anatomical descriptor we use to describe this lymph node region is the supraclavicular fossa, and then historically the triangle of Ho. Clinically, these lymph nodes were defined back in the mid-70s. They were originally omitted from that initial CT image-based definition published back in 2003. They were added in a separate publication in 2006 and labeled as the supraclavicular fossa. And so these are the pictures of the contours back from that 2006 publication when they were added in. And then when the system was updated in 2013, then we came up with a new label for them, which is level 5C. And basically what they were trying to do is go back and make the anatomy fit to what would have been treated traditionally in an LAN field, so that low anterior neck field. And so if you have done a lot of 2D planning and have done a lot of these LANs, I think it's useful when you're done with your contouring to go back and look at your contours on a coronal image set to see if what you have contoured down in the low neck is coming out laterally enough so that it makes sense to what would have covered if you were coming in and putting an LAN field on this patient. I would say that level 5C probably has the most variability of contouring out of probably all of the lymph nodes within the head and neck. I think a lot of it does have to do with the lack of having a definition at the first publication back in 2003. And then, like I said, what most people do is they're trying to contour out anatomy to make the LAN dosing distribution make sense on a CT scan. The one posterior neck OAR that I was assigned to go over was the spinal cord. Usually as we're contouring this for like an IMRT case, we define this as the true cord. Cranially, we contour from the tip of the dens or C2 inferiorly, at least, several centimeters below the PTB. So usually that anatomical definition is 5 centimeters so that you can accurately calculate out a DBH for the spinal cord. Moving on to indications for elective level 5 coverage, I think it's first important to make sure that we understand what we mean by elective. Elective just very simply means when would you want to contour level 5 and include that in your prescription when level 5 is radiographically negative. And so the things to think about would be definitely nasopharynx. So we would cover level 5 bilaterally for nasopharyngeal malignancies. If you have a high-risk cutaneous squamous cell carcinoma of the posterior scalp or neck, you would consider covering level 5 in the ipsilateral neck only. So nasopharynx bilateral, high-risk cutaneous cancer, ipsilateral. And then as far as other head and neck subsites, such as the oral cavity, oropharynx, larynx, and hypopharynx, you would make sure to contour level 5 in the lymph node positive heavy neck. And we'll get to that as we're getting to the contouring examples at the end. And then, of course, I didn't include it here, but we mentioned previously thyroid malignancies. Again, it's not very common that we use external beam radiation for thyroid malignancies, but for an anaplastic thyroid carcinoma, for example, in the postoperative setting, you would be covering level 5 bilaterally, even if there was no pathologic or radiographic lymph node involvement in level 5. Now we're going to come back to that first Zoom poll, so the one that we just did.
Okay.
Or actually, maybe it wasn't even that same question, but for the first Zoom poll that I have, we have a 45-year-old patient who presents with imaging concerning for malignant involvement of level 5 nodes with an unknown primary site. What is the most important to consider? A cutaneous cancer of the posterior lateral neck, laryngeal squamous cell carcinoma, esophageal squamous cell or adenocarcinoma, or a salivary gland tumor. And so looking at the poll, I think everybody got this point. This is excellent. You are all correct. The correct answer is A, cutaneous cancer of the posterior lateral neck or scalp. And then the next Zoom poll, in which of the following patients would be most appropriate to consider elective ipsilateral level 5 coverage? And I think we probably need to add the qualifier only ipsilateral level 5 coverage. So A would be a 60-year-old male with nasopharynx cancer. B would be a 60-year-old female with high-risk cutaneous squamous cell carcinoma of the posterior scalp. C, a 60-year-old male with a T1N0 hemineck laryngeal squamous cell carcinoma, or D, a 60-year-old female with a T2N0 oropharynx squame. And so looking at the poll.
In the chat, most of the people were B.
B, and that's correct.
For high risk. Yeah.
Exactly. And so again, we're trying to bold the ipsilateral. So the cutaneous, you would just cover ipsilateral. Nasopharynx, you always cover bilateral.
Yes.
So in conclusion, level 5 represents the posterior triangle or lymphatic chain within the neck. Level 5C represents the supraclavicular fossa. Interpretations of level 5C are highly variable as the anatomy of the low neck varies greatly from person to person. As we were discussing with that question about how to really define that posterior border, I think it's always important to remember that any of these anatomical definitions are simply guidelines, and that you definitely still need to evaluate your individual patient's treatment planning CT and parameters of their cancer diagnosis to make sure that sticking with the strict definitions makes sense for that patient, or do you need to try to tailor that to that individual person? In this case, I think it's also useful as you're transitioning to the IMRT era, do not compromise the target contours to avoid overlap with OARs. So I'm going to pull up some of these cases in Prono, and I am going to actually go back. I would rather, I think, start with one of the oropharyngeal cancer cases. And so in this patient, I think the description of the case was a little bit contradictory, but when I was reading through this case, it sounds like we had a 63-year-old patient that had a palatine tonsil cancer. So this is an oropharyngeal cancer, a P16 positive or HPV mediated oropharyngeal cancer. They had undergone a tonsillectomy and then had a left cervical lymph node conglomerate, which was also resected. The remainder of the lymph nodes were negative. From the description, they don't necessarily state where the lymph node conglomerate was located. So we'll take that with a little bit of a grain of salt, but we can at least make some educated assumptions. So basically what we're dealing with is a postoperative oropharynx. We had a left tonsil tumor that's been resected, and then the left neck that's been dissected that had lymph nodes in it. And so from the standpoint of contouring, usually for a post-op case, I think of doing dose painting in 2 dosing levels. So the most common dosing regimen that we would use in the postoperative setting at our institution would be a high-risk volume going to 60 gray at 2 gray per fraction over 30 fractions. And then the low-risk volume we treat to 54 gray over 30 fractions. So that runs at 1.8 gray per day. So usually with that in mind, that's what we do. Now for a post-op case like this, my high-risk volume, which again would be my 60 volume, I would be including the post-operative tonsillar bed, and I would also be including the lymph node levels where the lymph nodes were present prior to the surgery. And so in this case, we could just make an assumption, or just from the standpoint of the discussion today, let's just assume that the lymph node conglomerate was in level 2. That would be by far the most common location for a tonsillar tumor to spread. So if we had left level 2 lymphadenopathy, then I would be including level 2 in my 60 gray volume. As far as the remainder elective volume, and again, elective means where we're going to target and what we're going to treat, even though radiographically or pathologically, we did not see any lymph nodes in that area. In this case, for the left neck, so again, that's where the lymph nodes were present, that's the lymph node positive hemineck, I would include basically the remainder of that whole neck, so levels 3, 4, 5, retrostyloid, and retropharyngeal, so level 7 as well. And so with that in mind, as we're scrolling through here and specifically focusing on when and where we would want to start contouring level 5, again, from the description, it said that there was only left neck lymph nodes. So we would be contouring level 5 on the left neck only. And so again, what we're looking for the superior border of level 5, we're going to identify the hyoid bone. So that's this white, bright white structure here. And I'm going to scroll down for just a second. Here we have thyroid cartilage in the larynx. So I just wanted to point that out to people. And then I'll come back up to the hyoid. What we're looking for is very specifically the superior aspect of the body of the hyoid. And here, just due to the neck flexion and a little bit of rotation, we're catching the hyoid bone a little bit higher on the right first. So you could use this since you're starting to see the top of the body of the hyoid bone, which is the anteriormost aspect. So you could start contouring level 5 at this location. And so if we start editing this again, I would be putting level 5 in my low risk volume, which would be my 54 gray volume. So again, we would be contouring from the posterior aspect of the sternocleidomastoid. So I would have contoured my levels and 3 all the way back to the sternocleidomastoid here. So this example is a little bit short. And then all the way back to the trapezius. And so early on, sometimes you can have to curve around like that, depending on the patient's anatomy. The next patient we'll look at doesn't necessarily have that. So you're contouring something like this. And then as we're coming further down, level 5. And then we're seeing a lot more of the post-operative changes here. Oops. And so then coming down further, when we really start to see the trapezius change shape. So down here at this level, I would be contouring this something like this. Here. And so again, I'm just focusing on the level 5 aspect. And then usually for a post-op neck, you'd be including the entire sternocleidomastoid in your volume, which is a little bit different. So I probably would have modified my levels 2, 3, and 4 a little bit more as well. And then here, we can start to see the transverse cervical vessels here. So you could contour down something like this. And then I'm losing my, let's see, how do we pan? Apologies, I don't know how to, or this, there we go. And so we could contour just to the the anterior aspect of the trapezius there. So that's how I would approach contouring level 5 in this situation for this particular case. The other oropharynx cancer case was very similar. That one truly had N2 disease, so that's bilateral level 5 inclusion in your low risk volume. And then we were also given a nasopharynx case to look at as well. And so this ends up being a little bit more of a complicated nasopharynx case. And so I'd like to just scroll through the imaging first, and we can start up a little bit higher. So we've got the nasopharynx primary here. I'm going to focus my attention on the left neck here. So we have a lot of pretty bulky lymphadenopathy. So level 2A, level 2B. We have some right-sided 2B lymphadenopathy right there. And then as we're coming down, here is our hyoid bone. So again, this is probably the first slice of level 5. This lymph node back here is probably, junctioning level 2B/5. So we truly have lymph node involvement in level 5 on the left. And so nasopharynx is quite a bit different from most of the other head and neck subsites. In this situation, what I would have done is contoured out the lymph nodes in a GTV, which it looks like we have a lot of them contoured. There's some shoddy lymph nodes further back and posteriorly in level 5 back here.
No,
so normally, I'm sorry, go ahead.
No, I think it's a microphone open. Sorry.
Oh, sorry about that. I will continue then. So normally what I would do is I would create a GTV and contour the lymph nodes. It looks like here this contour was actually created as a CTV. I would have contoured lymph nodes out as a GTV. From there, I would place a 5 millimeter expansion on gross disease to create my high risk CTV in the neck. And then for the intermediate risk volume, the remainder of level 5 would be included in the intermediate risk volume. And so it becomes a little confusing because again, the CTV60, that's our intermediate risk volume. That's technically what we would be doing to include the bilateral level 5. So this is the one exception where for level 5, you're going to put that in an intermediate risk volume or a CTV, 60 to 63, depending on what dose painting schema you're using. whereas any other disease site in the head and neck for elective coverage, you would be putting that in your low risk volume. And so for me, if I wanted to start over, that would probably give you the best example. I would try to create a new structure here. And I'm going to turn the CTs off for just a moment so that we can look at this example. That we have quite a bit of lymphadenopathy here. And so most of your level 5 at much of the level here is going to be included in your high risk volume. And then I apologize, I don't know how to use the interpolation feature in this particular program very well, but I'm just kind of contouring out a few slices so that you can get the general gist of it. And then from there, you know what, I apologize, I don't know how to do the expansion tool on here, but that's what I would next. I would do an expansion to 5 millimeters on this to create my CTV 70, my high risk volume. This is a situation where you can see a lot of extra nodal extension here in the fat space. It does not look like we have sternocleidomastoid invasion. So I would edit my CTV 70 back to the deep aspect of the sternocleidomastoid. So you're basically editing that off of normal anatomical boundaries. And so any residual level 5, you're going to be contouring again into your intermediate risk volume. And so for me, if I were to change this, so to create my intermediate risk, I'm going to make sure that I'm catching that tiny little lymph node back there. And so this is an example. We have pretty posterior lymph nodes. If we scroll up and down, we have some vessels back there too. But this is a case, you have so much disease, you may want to just be a little extra careful and cover some of this extra space a little bit more posteriorly. And again, now that's something that would be definitely stylistic. So I apologize, I don't know how to use the interpolate or the expansion feature in this particular program. So hopefully that was a good enough example. But if anybody has questions on these cases, I'm happy to take those.
Yeah, great explication. Thank you, Dr. Lisa. In the chat, we have about the bolus for skin when there is a skin compromise. What kind of bolus do you use, or do you recommend or
Typically
prefer?
what we use is a superflab bolus. We have the option of using different thicknesses. Usually for the head and neck IMRT cases, my preference is to use the 3 millimeter bolus. Basically what you're doing is hopefully you have enough information based off of your diagnostic imaging and clinical exam that you have a pretty good idea of where that bolus needs to go. So our preference is to place bolus directly on skin, cut that at the time of CT simulation, and then make the mask so that the bolus goes inside of the mask. And you're using the immobilization mask to hold the bolus flush up against the skin surface. So that's usually our preference. The 3 millimeter tends to fit well. You could, in theory, use thicker bolus. It's just, I think, a little bit more complicated on a daily basis to really get it into the mask and to get it.
Okay, thank you.